My role really is to deal with the male side of things. I just want to take you through my thought processes in how to try and maximise outcomes for men with fertility problems. It's always, or it's normally through the gynaecologist that couples are referred, and so there are plenty of clinics where the men never get to see a urologist or an andrologist, which is kind of surprising when you think that in 30% of couples who have fertility problems, it's entirely a male problem, and in another 20% there's a male factor that contributes. So I must say that I feel very passionately that it's important that that these men do see an andrologist. There are two groups of men that we would see: the azoospermic men, where there's no sperm in the ejaculate at all, and then also the patients who've got OAT, and that's less than 15 million sperm per milliliter. And Thanos has already gone through very comprehensively the possible findings from the semen analysis. The most significant change over the last 40 years has been the progress from conventional incubation of sperm with eggs to this process of ICSI. And the process of ICSI means that with very, very few sperm, couples have still got a chance at having a baby. But what that's meant is that for some couples, the men aren't offered a full evaluation, because the thought is, well, we've got some sperm, why bother evaluating the male side of things? And so the male partner in this study was routinely bypassed in between 18 and 27% of couples. But in my experience, patients before they get here have very rarely been seen by a male fertility specialist. We can also treat underlying causes of male fertility, such as a varicocele, which can increase natural pregnancy rates and also improve success rates with assisted reproductive techniques. And the other thing is that some of these men, they have poor fertility because they have an underlying medical problem. And in this study, 6% of men were found to have an undiagnosed medical condition. Recent other studies have shown an increased mortality in men who've got decreased fertility. So it's very important that these men are assessed holistically. I've diagnosed 2 patients here who've had testicular tumours with OAT or azoospermia who hadn't been assessed or examined before. So it's really extremely important. And these are some of the myths that that surround male fertility treatment, and some of the things that I've heard directly from patients, even in the current era. So you've got no sperm, there's no sperm in the ejaculate, there's no chance that you're going to be able to be a biological father. Or you've had chemotherapy before, there's no point in trying to find sperm because we won't find any. There's still this link between a high FSH and the thought that you won't find sperm, but in fact the studies show no linkage at all once you've got a patient with NOA between the severity of the high FSH and the chance that we'll find sperm. And then finally, I hope that I've debunked this myth that if you've got OAT and there are some sperm that can be used for IVF, that you don't need to see a urologist. So for me, in trying to help overcome male factor infertility, the most important thing is to try and establish a cause of, we're talking about azoospermia now. And that helps me to plan my treatment and also to optimise my chances of finding sperm at SSR. The etiology of non-obstructive azoospermia is unknown for the vast majority of patients. We simply have no idea why there are no sperm in the ejaculate. These are men where there's no obstruction there, but the problem is that the testes aren't producing sperm normally. And it's very unsatisfactory for us as doctors, clinicians, and also for patients when we say to them, look, we really have no idea why you're not producing any sperm. For me, the male factor evaluation is just like we would do for any other patient that we see in medical practice. You take a history, you examine them, and you look at the results of your tests. I'll flip this slightly in a minute because in fact what we look at first is the semen analysis. We've talked about that already, and I'll come back to that. So the history for male factor patients, I have to say that my history, they're always seen as a couple, my history from the female partner comes down pretty much to do you have a period and is it regular? I then leave things over to the experts in that. But it is important to consider, you know, the couple, and, you know, all the time I'll see patients where I think, look, things aren't quite right for whatever reason, from your history, from some surgery you've had. Before I go and try and find sperm from the male partner, I think it's important that you're assessed by a gynecologist to try and work out if it's actually worthwhile or not. Erections and ejaculation are clearly important, and ejaculation is especially important for men with a history of diabetes, where there may be a suggestion of retrograde ejaculation, where they may have had surgery before that will affect those reflex processes. Obviously, have you been responsible, or has your partner had any previous pregnancies, is important. We do see secondary infertility, and I've seen azoospermia from where all intents and purposes the man has fathered a child 3 or 4 years previously. This is really the key, though. It's the past medical and surgical history for me that determines the likelihood of whether it's a non-obstructive azoospermia or an obstructive azoospermia. So just going through some of the things that might help tell me, this is a patient who's got a testicular tumour and gynecomastia secondary to that. So this is a patient who will have had, who's more likely to have a non-obstructive azoospermic cause. This is a mesh, very topical at the moment, meshes. This is an inguinal hernia repair, and they've been associated with desmoplastic reactions around the vas, causing an obstructive azoospermia. This is a patient who's got testicular torsion. Clearly they've got a normal contralateral testicle, but we think that whatever has caused the testicular torsion, or an undescended testis on the other side, may also be associated later on with male factor infertility. This is, what was his name? Is it Vinnie Jones? Yeah, and Gaza. Yeah. Testicular trauma may be relevant. And then very, very relevant and topical is varicocele as well. And that's really quite contentious. So these are some of the things that you might want to think of. Occasionally you'll see somebody come into the clinic who is built like they spend all of their days and nights in the gym. And they're sat there with their partner, and they have absolutely no idea why they've got no sperm in the ejaculate until you start having the discussion with them and ask them if they use steroids or if they use testosterone supplementation. And then you can see there's a very difficult interaction going on between the partner and the man because they haven't been completely aware of what's going on. So it's really, really important just to remember that this can have a significant effect on male infertility. And it may not just be bodybuilders, but it may be very well-meaning other doctors who have seen a man and they've got hypogonadism, which is often associated with male factor infertility, and they've thought, oh, we'll improve the male infertility by making your testosterone higher, and that has exactly the opposite effect. So taking a history for this sort of thing is absolutely crucial, and there are a range of drugs that can affect fertility in various different ways. So taking a history is absolutely crucial, and that includes also a lifestyle history. You know, the evidence on tobacco isn't great. It probably does affect sperm counts. It certainly affects sperm DNA. Alcohol, the evidence is fairly mixed. I think that probably a glass or two of red wine occasionally is fine. Clearly, if you're having 20 pints a week, that's probably not quite so good. And there are various other lifestyle measures which can affect fertility. So that's the history. So I'm starting to get an idea of, is it likely to be an obstructive azoospermia or a non-obstructive azoospermia? And the physical examination is absolutely crucial. So generally, are they well androgenized? You know, you see some 25, 30, 35-year-old men who look like, you know, they haven't really gone through puberty. Are they well androgenized or not? Have they got normal body hair pattern? And then the external genitalia is absolutely key. Any scars in the groin? Have they had a hypospadias or some other abnormality which might suggest a problem with development of the external genitalia? but it's really the size of the testes and their consistency which is key, and then whether you can feel a vas deferens and what does the epididymis feel like. Okay, so in men who've got a non-obstructive azoospermia, they've got small testes, they've got a vas present, the epididymis doesn't feel particularly full. In men when there's an obstructive azoospermia, they've got normal testes, for instance, of patients who had a vasectomy, normal sized testes, obviously you can feel the vas, and the epididymis is nicely dilated. So that just helps to give me an idea as to whether it's a blockage or not. And then clearly we've got our lab evaluation. We've talked already about the semen analysis, but for me it's the blood tests. What's the FSH level? What's the testosterone? And then also some appropriate genetic tests, and I'll talk a little bit about those in a minute, because doing the whole gamut of cystic fibrosis, karyotype and Y chromosome microdeletion on everyone is a complete waste of everyone's time and money. Thanos has covered this extremely comprehensively, but just to say that these were the first evidence-based criteria for semen analysis results based on actual patient outcomes that have been available. Before that, it was a group of experts sitting around a table saying, oh, well, we think that X million sperm per milliliter is a reasonable count. So I think this has been a really positive step forward in the analysis of male factor infertility. So, with that background, I have a patient who comes to the clinic, and most of the patients I see are azoospermic. I mean, you know, I think that we offer a very good service here for men, because often men with severe OAT will come and see me as well. But the majority of men that I see have got azoospermia. And in order to assess them, it's important just to remember the anatomy of the male reproductive system. You know, you've got the testicle, goes into the epididymis, into the vas, and then that joins the ejaculatory duct where the seminal vesicles also empty out. Now the key is that most of the ejaculate comes from the seminal vesicle, 70% or so. It passes through the prostate then, where another 20% is added, and the stuff that you get from the prostate is acidic. And in fact, only 10% comes from this part of the reproductive tract. So 70% from the seminal vesicles and 20% from the prostate, which is the acidic portion. So the first thing that I do when I see a semen analysis is I work out, is it a low volume acid ejaculate or is it a normal volume alkali ejaculate? And low volume acid ejaculate means I've got nothing from the seminal vesicles. Okay, it means there's some kind of blockage or problem with the seminal vesicles. This is a typical situation. You've got a volume of 1 ml, you've got a low pH. You know, some people are doing fructose assays and all sorts of things. You don't need it in order to tell you what's going on. I know that there's no contribution then from the seminal vesicles, and therefore there's only one of two possible diagnoses for these patients. They've either got no seminal vesicles because they've got congenital bilateral absence of the vas, or the contribution from the seminal vesicles is blocked and they've got ejaculatory duct obstruction. So these patients are making sperm normally, they're going to have a normal FSH, they're going to have a normal testosterone, and I can make my diagnosis by examining the patient, have they got a vas there or not, and if necessary, by doing a transrectal ultrasound to look for some kind of midline cyst and tell me is it ejaculatory duct obstruction, or by doing an MRI of the prostate or pelvis. So these are very special, small group of patients. And so it's very hard for me when I see a patient with azoospermia who's referred on the East of England criteria, where I haven't got a semen analysis to look at, because I don't know, is it normal volume or not, and is it acid or not? So actually having that is very, very helpful to me to work out and be able to counsel the patient, are you making sperm normally or not? So congenital bilateral absence of the vas, one of those two possible diagnoses. They've got a little epididymal remnant, but they're making sperm normally. So it's really, you know, good news for them. It might be the first time that they've been told that they've got an abnormality of the cystic fibrosis gene. Clearly they need a cystic fibrosis gene screen, but most importantly, so does the partner. And then once you've done that, they can have some genetic counselling as to the risks of them having a child with cystic fibrosis. But the good news is that we will always find sperm in these patients.
Why would you screen the partner if they were negative?
Well, these patients tend not to be negative. So they almost all have an abnormality of the cystic fibrosis gene screen if they've got congenital bilateral absence of that. They may not have clinical cystic fibrosis, but they will almost all have. Now, if you do their analysis and it's negative, we only test for the 85% commonest mutations. So there's still a risk that of those 15%, we may not have picked up one of those. So I still think it's worthwhile if they are negative to have a look. And then they can be properly counselled as to the risks. So that's why we screen for the gene. Good news is we'll find sperm at surgical sperm retrieval. That can then be used for IVF and ICSI. For ejaculatory duct obstruction, we can do an operation. This is a slice through the prostate. We get a little loop and we go up the urethra and we will then basically resect or slice off the top of the ejaculatory duct to try and release that obstruction. And that is one way of managing these patients. You can see here we've injected some dye into the vas and you can see it's blocked here in the mid-urethra. And so we basically pass a telescope up here, scrape that off and try and open up to find some sperm. So that's one small group. The other group is normal volume alkali ejaculate. And in those patients, you've got seminal vesicles, you've got open ejaculatory ducts. And so then it's that diagnosis between non-obstructive or a blockage of some sort. Non-obstructive because of testicular failure, obstructive because there's a blockage of the vas, such as vasectomy, or epididymis, maybe recurrent infections or something like that. So we've taken a history to try and help us. We've examined the external genitalia, and then we're going to do some blood tests. And the FSH is actually the really key blood test here. But the lab doesn't help us very much because the normal reference range in a lab is between 2 and 12. But in fact, men who are making sperm normally, their FSH is normally less than 5. So I'll also get letters which will say, oh, they've got a normal FSH. And it is normal in the normal reference range. It might be 9, it might be 10. But to me, if it's 9 or 10, that suggests that there's a problem with spermatogenesis and it's more likely to be a non-obstructive cause than an obstructive cause. So having the absolute values actually is also really important. Testosterone is obviously key for spermatogenesis. The levels within the testicle are 100 times higher than in the peripheral circulation. And it's important that they're high to support sperm manufacture. And often if the testicle isn't making sperm very well, it also doesn't make testosterone very well either. And so in some patients we will consider trying to boost testosterone manufacture endogenously by giving Clomid, which for the gynecologists and the female fertility specialists in you, it works in exactly a mirror way in our patients as well. So combination of history, diagnosis, looking at the testicular size and whether the epididymis is full or not, and the FSH will help me differentiate between non-obstructive and obstructive azoospermia. Fortunately, the situation where urologists and gynecologists take men to the operating theatre to do a biopsy to find out if it's obstructive or non-obstructive are over. I haven't seen any patients like that for 2 or 3 years because these patients should be evaluated at the same time as you have the facilities to store sperm. But you don't need to do a biopsy and you don't need a vasogram either because with that algorithm you can actually determine whether it's obstructive or non-obstructive. So this just shows that in obstructive azoospermic patients, FSH tends to be lower, testicular length tends to be greater, and in non-obstructive patients you tend to have a higher FSH and a lower testicular length. Here the cutoff is 7.6. In other studies it's around 4.5 to 5. So for me it's 4 to 5 will be my cutoff. And then once I've made that diagnosis, that then directs the further tests that these patients need. So if in non-obstructive azoospermia, that's when you then do a karyotype and a Y chromosome microdeletion. You don't need to do a cystic fibrosis gene screen in them. And equally, in the patients with obstructive azoospermia, you don't need to do a karyotype or a Y chromosome microdeletion either. So it's really important that we use our resources appropriately. They're expensive tests, and only use them when they're going to try and help improve our treatment of patients. The genetic tests that we do are basically a karyotype, which looks for Klinefelter syndrome, which is where they've got 47. You can see there's an extra X chromosome here. It's not all patients with Klinefelters who've got very, very low androgen levels. So you may be the first clinician they see who makes that diagnosis. You examine them, typically they've got very, very small testicles. Their FSH levels may be very high, but not necessarily, and they can have quite a varied presenting testosterone level, and we can get sperm from them at SSR. Y chromosome microdeletion is the next test we do, and I think that's probably more important actually than doing a karyotype, because we know that if we find an AZFA or an AZFB microdeletion, which are the two least common ones, that we won't find sperm at surgical sperm retrieval. So you can counsel your patient appropriately, and they can avoid what's quite invasive surgery if you know you're not going to find sperm. If they've got an AZFC microdeletion, you will still find sperm in about 50% of them, but it's important they know that if they have a boy from the treatment, that baby's also going to have the Y chromosome microdeletion. It's not known to be associated with any other somatic problems, but counselling for them I think is important. So the patients with non-obstructive azoospermia will have a karyotype, and they'll have a Y microdeletion as well. And some patients with a Y chromosome microdeletion, you can sometimes find some sperm actually in the ejaculate too. So that's what we do genetic test-wise for patients with non-obstructive azoospermia. So we've made our diagnosis. How do we treat our patients? So if you've got obstructive azoospermia, which is a normal volume alkali ejaculate obstructive azoospermia, or you've got congenital bilateral absence of the vas, in those patients you can do a PSAR. Okay, stick a needle into the epididymis, suck some sperm out, goes to the embryologist, it's frozen. This is what we used to do for TZ, so testicular sperm extraction. This is an operation that you do for patients who've got non-obstructive azoospermia, so a problem with sperm production, and do multiple biopsies of the testicle. This is a relatively normal sized testicle. You slice off these little bits of tissue, you give them to the embryologist as well, who mashes them up and says, yes, there are sperm, or no, there aren't sperm there. But it's a fairly, I would say, barbaric operation when looked at like this. And now we've actually evolved, and we've been offering, I think, micro-TZ here probably for 4 or 5 years. And although the initial incision on the testicle is larger, in fact, the effects on the testicle are much less. So it's a general anaesthetic with a midline scrotal incision. We use an operating microscope, and we look for dilated opaque tubules. You can see here, we open up the testicle, we essentially bivalve it, so open it up like this. We then dissect between the tubules, and all the time we're looking under the microscope for dilated tubules, because those are the tubules where sperm are most likely to be found. So there's our initial incision. This is where we open it up. This is one of the views you get under the microscope, and rather remarkably you can see that with some monocryl the testicle comes back together at the end and looks relatively normal at the end. And this is the theory behind it, that these big or fatter tubules compared to these tubules here are the ones more likely to contain sperm than the tubules which don't look so fat here. And there's a video that I'll show you now which shows really quite nicely all of these are tubules which don't look anything impressive at all, and dissecting through that you can then suddenly see this group of big white fat tubules there. So that's what we're looking for on micro-TZ. It doesn't always look like that. This is a really nice example of it. But selectively, we remove those tubules. This is just with a little diathermy. We've got continuous flushing. We remove those tubules and give them to the embryologist. And you can see in comparison, the other tubules which are left behind, they're all pretty thin, not very impressive at all. And those are the tubules that we're looking for that are most likely to contain sperm. So that's the process of micro-TZ. And the success rates of micro-TZ are higher than with the conventional TZ that I showed you before. So if we look at the overall column here, these are all different papers. Overall column, the success of micro-TZ was 44%, and with the conventional technique by the same authors in the same hospital, so you assume the same patient groups, which is important, the retrieval rate with standard TZ was 17%. And here from Peter Schlegel's group, who actually described the original operation, you can see it's 32% with conventional technique versus 57% with the micro-TZ. So a significantly higher chance of finding sperm in those patients. And the chance of finding sperm with micro-TZ depends upon if they've had TZ before or not, what your chance is. So if they haven't had conventional TZ before, your chance is 56%. If they've had a standard TZ before but just 1 or 2 biopsies, you've still got a 50% chance of finding sperm. That goes down if they've had 3 or 4 biopsies per testis, but it's still worthwhile doing this procedure if patients have had a standard TZ before, particularly if the number of biopsies per side has not been particularly high. So here you can see patients who on one side had conventional TZ, on the other side had micro-TZ. You can see the increased retrieval rate with micro-TZ compared to conventional TZ. And then you can look at the acute changes on ultrasound of the testicle, both acutely and chronically. And you can see that from that point of view, micro-TZ certainly looks like a better option than conventional TZ. This is the study that just shows that it doesn't really matter how high your FSH is. Once it's high, it doesn't matter how high it is, it doesn't really affect your chance of finding sperm at sperm retrieval. So if I've got a patient with an FSH of 50, 60, it really doesn't make me think, oh, I'm less likely to find sperm in this patient. So micro-TZ is great. I was really delighted when Mike and the team said that we could buy a microscope. That was 4 or 5 years ago. I don't think that they really believed that we'd use it as much as we have done, but we offer it now as standard to all patients who come, who are part of the East of England referral pathway to maximise their chances of a successful outcome. The testicular trauma is less, the chance of sperm being found are higher, and also the hormonal difference in testosterone is also less. Varicocele is highly contentious, and I've had some correspondence with gynecologists from around the region who say, oh, you've asked us to arrange for this patient to have their varicocele treated. The NICE guidance says it's not worthwhile doing, but there is quite a bit of evidence which would say that for clinical varicoceles like this, okay, not for grade 1 varicoceles that are only detected on ultrasound, but for patients where you can see a varicocele or palpate a significant varicocele, where there are abnormalities in the sperm count and obviously infertility, that it's worthwhile treating those patients. It is associated with OAT. At the left side, varicocele is much, much commoner than the right side, and it's just a dilatation of the veins that surround the testicle. So the NICE guidance doesn't support it. The EAU guidance says that you can treat men with a clinical varicocele, oligozoospermia, and otherwise unexplained infertility. The evidence is weak, but I certainly think that it's worthwhile recommending to the couple, for all couples where there's a grade 2 or grade 3 varicocele who meet these criteria, we would arrange varicocele treatment, and for us that's normally varicocele embolization. So just finally, I just want to touch on Clomid. I haven't covered all of the potential diagnoses that we face, but hormonal treatment is handed out in various parts of the world to men with male factor infertility without a lot of evidence. I think that the only real evidence base for giving HCG plus or minus FSH and HMG is if you've got hypogonadotrophic hypogonadism, and that's then managed by an endocrinologist normally. For patients who've got non-obstructive azoospermia, a lot of those patients will also have low testosterone levels. So this, for those of you who like Twitter, instead of take-home messages, it's tweet-home messages. So this is the complete algorithm, which was actually drawn up by a medical student who I ran through this with. And this just summarizes everything about the analysis that we've talked about for men who've got azoospermia. The low volume acid group, and then the majority who fall into the normal volume alkali ejaculate, how to evaluate and then how to treat them. And then just finally, just like with any patient, male factor patients, we need to take a careful history, examine them, and then organise appropriate tests, thinking of the cost of those tests. I would advocate, obviously, I'm a urologist, that these patients should see a specialist who can examine them and diagnose them. Our working diagnosis drives the further tests that we do, and then also the prognosis for sperm retrieval and the way that we're going to retrieve sperm. And then we'll consider adjuvant treatments to try and increase our chances, such as using Clomid. Thank you for your attention.